Morning. Thank you for having me. Um, the way I have my screen optimized, I can't see you, so try and pop up a message if there's something going wrong. But I am going to talk today about behavioral treatments for pediatric insomnia, so turning away from circadian rhythm and talking more about those troubles falling asleep and staying asleep. So I'm going to review first the diagnostic criteria for insomnia, and then I'm going to talk about some empirical support for the interventions that I recommend, and then talk a little bit about behavior theory, which you may have learned in school, but it's been a while because that's very important to understand how the interventions work, and then talk about insomnia treatments across development because it slightly changes from infants to adolescents. So starting first, behaviorally based sleep disorders in young children, we used to have a different name for it, and now we simply call it insomnia. So with the most recent version of the International Classification of Sleep Disorders, insomnia became a single disorder that encompasses children and adults. Anything marked in orange here is the difference between the old version and the new version. So the new version focuses on the fact that insomnia can be a caregiver report. And so it doesn't just have to be a patient report because it's pretty rare that a 2-year-old complains that they're having trouble sleeping. So the diagnosis can be based on a caregiver report. In addition to the standard criteria for insomnia, which are difficulties falling asleep, difficulty staying asleep, or waking up too early in the morning, you also can have resistance to go to bed at an appropriate time. So that's something you see a lot in young children who refuse to go to bed. And then you can also have the sleep onset association type, which I'll describe more later, but basically it's difficulties falling asleep without some sort of support from a parent or caregiver. Again, all of the sort of daytime symptoms are similar in children. What is different, and I don't have marked on here quite as much, but academic performance, attention, those are things, family impairment, those are things that you don't necessarily see in adult insomnia, but definitely see in children with insomnia. And you can also see behavior problems. So children have more hyperactivity, impulsivity, and aggression if they're having insomnia, not something you typically see in adults. And finally, it's really important that before you can diagnose insomnia, you have to make sure that a child has enough time to sleep. Because if you're only giving, for example, in adolescence, if they only have 6 hours to sleep and they're very sleepy during the day, you can't say it's insomnia because they haven't been giving themselves enough time to sleep. So it's very important that an adequate time is allotted or allowed for the children to sleep. So this is a cartoon. We joke that, by the time patients come in to see someone like me, the father says to the child a story, honey, wouldn't you rather a mild sedative, right? Parents want a quick fix. They want the medication. And I know most of your neurologists or physicians or medical providers who do medications, but what I'm going to be talking about today are behavioral interventions that are not necessarily a quick fix. There are no medications for sleep, for insomnia in children, and behavioral interventions work as long as parents are consistent. And again, I will talk a lot more about that in a moment. One of the first practice parameters or recommendations came out in 2006. We did a comprehensive review of the literature. At that time, insomnia was focused only on young children, so infants and toddlers and preschoolers, looking at the evidence. And again, that's now 15 years ago. That evidence was very strong. We updated it. This was an updated standardized review in 2014. Again, very strong evidence for treatments of insomnia in young children. The outcome of this review showed that there was not as many insomnia empirical studies for school-age children or adolescents or even children with special needs. This paper we just put out earlier this year, this was a more comprehensive review, not quite as stringent of guidelines. So it included small studies as well as large randomized clinical trials. And I pointed out here because these are a bunch of the interventions I'm going to talk about. So bedtime routines, parent education, extinction and reinforcement, and then stimulus control you heard a little bit about, and sleep restriction. What's really important to understand from this graph is that there's a ton of evidence still in young children. There's a lot more limited evidence in adolescents, although we know these interventions work. Similarly, there's a lot of intervention been shown for children with neurodevelopmental disorders, such as autism or ADHD, but a lot less evidence shown for children who have chronic illnesses or psychiatric disorders. All right, so now I'm going to turn to behavior theory and how that's important for the management of insomnia. This is a picture from a museum here in the United States showing rat basketball. If you've never seen this, my son and I visited this museum a few years ago, and basically they teach these rats to play basketball. So you can teach animals certain behaviors in children. As much as parents don't like me to say it, are pretty much small animals, and we can train their behavior. So there's some basic principles that we need to know to help shape their behavior as we want to do at bedtime. If you recall back, you may have learned about operant conditioning. So again, you're thinking back to your psychology classes and you're thinking about Skinner and Pavlov, but a behavior that's reinforced will increase in frequency, and a behavior that's ignored will decrease in frequency. So if you want something to happen, you reinforce it. So with the rats playing basketball, every time they pick up the ball, they get a treat. Every time they put the ball into the basket, they get another treat. If you ignore it, if you ignore the rat picking up the ball or putting the ball into the basket, eventually the rat is going to stop doing that behavior because it's no longer rewarded. There's different schedules you can use to provide rewards. A consistent and predictable schedule is something that happens every single time. This is very good for increasing and shaping behavior because you know exactly what to expect. An intermittent reinforcement schedule is something that doesn't happen every time. So every second, third, maybe fourth time you get the reinforcement. This actually can really make a behavior last for a long time. And if you think of it like gambling, right? So if you're playing on a slot machine and you pull the lever and you pull the lever and you don't win, but then eventually you win. If you pull 9 or 10 times, you win. And you're like, well, maybe if I just keep pulling, I'll win because I don't know when that reinforcement is going to come. And so that intermittent reinforcement schedule can actually make it very hard for a behavior to go away. When you switch from this inconsistency to a much more consistent behavior schedule, what's going to happen is the unwanted behavior is going to get worse. So the first night we do sleep training is going to be bad. The second night is going to be even worse. And I have some really concrete examples of how I explain this to parents in a couple of minutes. So first, let's talk about sleep onset associations. They are most common in children 6 months to 3 years, but I've seen sleep onset associations all the way through adolescence. And as students go off to university, they still sometimes need things to help them fall asleep. This is a picture of my son, who's now 11 years, but you can see things that helped him fall asleep were his pacifier, his baby doll, and then a couple of lovey, snuggly objects that he had in his crib. What we know about children, and you may have already heard, is that nighttime arousals are normal, right? We wake up at the end of every sleep cycle. So babies and young children are waking up every hour on the hour, and that's totally normal. That's not the problem. The problem is then they can't go back to sleep. Children who have positive sleep associations can help themselves go back to sleep. So my son here used to have 6 pacifiers in the corner of his crib. He could find them. He could go back to sleep. He did not need my assistance. What parents come in complaining about, though, are the negative sleep associations. So that's when you have to rock a baby to sleep or nurse them to sleep or put them in the car and drive them around or turn on the vacuum cleaner. Those things that involve parent help are very problematic to the parents because it disrupts their sleep. So that's what we consider a negative sleep association, is something that the child can't do on their own. And this is often tied with the inability to self-soothe. So children need to learn to be able to self-soothe and regulate. And so if every single time throughout a day a child cries, the parent comforts them, the child doesn't gain that ability to self-soothe, to calm, and to regulate. And that will then translate or carry over into the night. This is a video example. This is kind of a drastic example of a negative sleep onset association. I'm going to play it. Hopefully,
turn off the water. She wakes up to turn it back on.
You've heard of Pavlov's dog. This is Pavlov's daughter.
This is a baby who falls asleep with the water running.
She feels the temperature. And then she goes back to sleep. Do it again, Tyler.
There you can see that arousal. That's pretty drastic. Most sleep onset associations aren't quite like that. Most sleep onset associations look more like this video. This is a baby. This is taken off of share video. In Europe, we clearly don't recommend this type of bumpers anymore. But here's a baby crying at night. Wants daddy still has a lot of work to do, reports to write, things to get done, and baby won't go to sleep. And he does what he's been told to do, which is pick up the baby and lay her down over and over again till she goes to sleep. But she's a little too smart for that, pulls herself right back up because daddy's there and she wants his help to fall asleep. So he does what every good parent would do, which is crawl into the crib with her. And the reason why people do this is because he's there, she snuggles up against him, and if I count to 5, 1, 2, 3, 4, 5, she's asleep. So why would you not crawl into your child's crib if you could get them to stop crying and fall asleep that quickly? So here he is, he solved the problem except for one small thing. He still has a lot of reports to write. And now he's stuck. Well, if I just stay 5 more minutes, then she'll stay asleep. The 5 minutes have passed, and now it's like, okay, are you really asleep? Not answering to my when I call her name. If I scoop her one way or the other, then I can get out of this crib and go do all that work that's still waiting for me. Just one last check, make sure she's really asleep. Parents go through this every single night. Just have to wait 5 more minutes to make sure she's asleep. Here we go, building up the courage. I can do this. I can get out of this crib. All those reports are still waiting. Got it. He's moving. He's on his way. And wait. Oh, look, daddy's still here. Okay, so I'll spare you the rest of this long video, which eventually is he finds his way out of the crib, and as soon as he does, she stands up and starts crying again. So this is a negative sleep association in that she cannot fall asleep unless he is there. How I explain this to the parents is with my 2 pillows. I tell parents, I love sleeping on 2 pillows. And when I put my head on my 2 pillows, I fall asleep very quickly. It's great. And in the middle of the night, when I wake up, my 2 pillows are on the floor. Now, I may think the pillows fell off the bed and woke me up. But really what had happened was the pillows fell off the bed an hour earlier. I slept right through it. I didn't notice it. But when I hit my normal arousal and my normal wake up, I rolled over to go back to sleep, and I couldn't go back to sleep because my pillows weren't there. But if I scoop my pillows up off the floor and I rest my head on them, I'm able to go back to sleep. And then I look at the parent or 2 parents or caregivers, whoever I have in the room, and I gently point out your pillow number 1 and your pillow number 2, right? This child cannot fall asleep at bedtime without these pillows. Parents don't complain about bedtime. But if you can't fall asleep at bedtime without the pillows, guess what's going to happen when your child has normal nighttime arousals? They can't go back to sleep without the pillows. So that's how I help parents understand the behavior behind this. The second big type of behavior sleep issues that we'll talk about in terms of treating for insomnia are limit setting issues. This is where parents really struggle. You can set limits and say no all day long, but when you're tired at bedtime, it's really difficult. And so what limit setting issues look like are prolonged or really long bedtime struggles or bedtime refusal. So this is the child, one more drink, one more trip to the potty, one more hug, one more story. I think there's a monster here. I can't really think about sleeping. What are we going to do tomorrow? Right? They stall and they stall. And what this means is that it could take a child 2 to 3 hours to fall asleep. You typically see this in preschool or early school age children. Then what you can see for some families is that you have this very long, prolonged bedtime, and a parent finally says, look, I'll just lay down with you and you'll fall asleep quickly. And that's what we call a combined type. So you have that limit setting prolonged bedtime, followed by the sleep onset association of a parent helping the child fall asleep at bedtime. And then typically what you see in the middle of the night is a child who hops out of their bed and moves into the parent's bed. When we do behavioral interventions, as I said, consistency is key. We've got to have that continuous reinforcement schedule. It has to be consistent and predictable. So how I explain that to parents, I talk about paychecks, right? We all get paychecks. Mine comes twice a month on 2 certain days. If my paycheck doesn't come, I may think, well, it's a fluke, but I'll keep going a little longer because my paycheck's predictable. It comes every other week, right? And that keeps me going to work. That's how we as adults get reinforced for behaviors that are expected of us. Sometimes we need to reinforce the behaviors we expect of children. Now, an inconsistent reward schedule is like if you take a child to the grocery store and they see the candy and you say no. And the next time you go to the grocery store, you as a parent say no. And the third and the fourth and the fifth time you say no. But on the sixth time, you're really tired and you buy your child candy. Well, 1 out of 6 trips to the grocery store to get candy, those are pretty good gambling odds for young children. So every time you go to the store, you can pretty much expect that your child is going to ask for candy. Now, what happens when you try and change that behavior? So this is an example from a colleague of mine, Dr. Valerie Crabtree, where we all have our favorite beverage that has caffeine in it, whether it be coffee or soda or something. And every day we put our money into a machine, that caffeine comes out and we're happy. It's predictable, it's expected, it makes us happy. Every single day this happens. And then one day you put your money into the machine and nothing happens. Your beverage doesn't come out. You're not getting your coffee or your soda or whatever it is that makes you happy. So this is going to make you mad because you're not getting what you want. So you press the coin return, you press all of the buttons, you may even shake the machine because you really want what you're used to getting. Nothing happens, and you may think to yourself after about a half hour, okay, the machine's empty, I'll come back tomorrow. So the next day you go back, you put your money into the machine, nothing happens. Now, remember, you didn't get this yesterday either, so you're pretty angry, unhappy, upset. You're pressing the buttons, you're shaking the machine, you may even kick it and yell at it. And if after a half an hour of kicking and yelling and shaking the machine, your soda pops out, guess what you've learned? Escalating behavior gets you what you want, right? Your behavior is getting worse. And by the soda coming out, you get reinforced for that bad behavior. But if on that second day, nothing happens again, you're going to give up. You're probably not going to come back to this machine again. And this is where, when I said behavior gets worse before it gets better, this is an example of how that behavior gets worse because you want what you want and you're going to throw a temper tantrum in order to get it. So when we talk about treating insomnia, we always start at bedtime. Even though most parents come in complaining about the middle of the night, we have to make sure bedtime is clearly solid and in place before we worry about the middle of the night. Naps are the last thing that we worry about. Sleep is really important during the day for young children, so we encourage parents to get naps in however possible. One thing to consider, though, is if the naps happen too late in the day, it's going to make falling asleep at bedtime even harder. So if you have, say, a 3 or a 4-year-old who takes an afternoon nap, that child is not going to be ready to fall asleep until 9 o'clock or 10 o'clock p.m. So a parent who has that child with a delayed sleep onset, it can even happen in young children, trying to put them to bed at 7 o'clock is only going to allow for a 2-hour bedtime battle. So really making sure bedtime aligns with when a child is ready to fall asleep. Every child and every adult needs a bedtime schedule and a bedtime routine. Bedtimes should be consistent 7 nights a week. They should not stray by more than an hour. You've already heard a lot about circadian rhythm disorders. You can throw off even a young child's circadian rhythm on the weekends by not having a consistent bedtime. Bedtimes should be age appropriate. We typically think of earlier bedtimes for young children, but as I just explained, some children may not fall asleep naturally early, especially if they have parents who are night owls. Those are children who may have a later bedtime. You need to have the same routine every night. It needs to be a positive routine, so something kids enjoy. If there's something a child doesn't enjoy, like brushing their teeth, do it first. You don't want to do it very last in the routine because that's going to upset the child right before bed. But the routines should be the same every night. They should move towards the bedroom or where the sleeping environment is, and they should be short. So an example, a bedtime routine can start with a snack and then brushing the teeth, using the potty, putting on pajamas, reading one book, and that's the end of the routine. Same thing, same order every night. By the way, that's a really good routine for grown-ups too, right? So having the same exact things. Now, to help children and families stay on track, you can use what's called like a picture chart. This comes from the Autism Treatment Network Toolkit. This is publicly available and you can download. It is designated and targeted specifically toward children with autism, but everything recommended in it works for typically developing children as well. So this is an example routine with a picture chart. Put on your pajamas, use the toilet, wash your hands, brush your teeth, drink the water, read the story, and go to bed. And this way, when a child fights back and says, but I want another story, you can say, I'd love to read you another story, honey, but the chart says we're all done for tonight, right? And it helps if there's two parents or caregivers in the home, it helps them to also agree on what bedtime should look like. And especially for kids with neurodevelopmental issues, it's very important to have this rigidity and have this consistency. If you don't want to do a picture chart, you can glue items onto a stick or onto a piece of fabric and hang it on the wall so children know exactly what's to come. Once you have bedtime in place, then we work on the interventions for infants and toddlers. So the first one we think about is standard extinction. This is hardcore cry it out. The goal for this intervention is to take away the sleep onset association, teaching the child to fall asleep and return to sleep all by themselves. This is hard. I rarely recommend this. Families who can do this don't come to see a doctor. They just do it. The idea is you put the child to bed at their set bedtime, and then you don't go back until the morning. You ignore them. You can monitor, and most families these days have video monitors or even just audio monitors, that if you're concerned a child's foot is stuck in the crib or perhaps they've thrown up, then of course the parent needs to go back in. But other than that, there is no going in. You simply ignore the cries at bedtime. You ignore the cries all night long. This works, and it works really well. It takes 3 to 5 nights. That first night is bad, as I said, and the second night is worse. The problem is it involves a lot of crying, okay? And parents have to be prepared for that. The other things parents have to be prepared for is that a child may throw up, they may vomit. And so you have to have a second set of pajamas ready. You have to have a second set of sheets so they can just strip the sheets off and put the child back in their bed or their crib. I hate recommending that to parents. The problem is that as young as 6 months of age, children can learn to throw up on demand. So if they're angry and they're not getting what they want, they can make themselves throw up if it gets them what they want. It's very rare that happens, but you have to prepare families for it. More commonly, what happens is you get one parent or caregiver who undermines it. So they're like, we're going to do this. The two parents agree, but then the weak one, and it's not always, it's either, doesn't matter who it is, the weak parent says, I can't handle this. And then they go in and rescue the child. And again, all the child has learned is that if I cry really hard for 20 minutes, mom, dad, grandma is going to come in and pick me up. So you have to be very careful about that potential happening. And then if you have other children in the home, it can be disruptive with the crying. But again, this is a very short period of time. And I'm always surprised. I always hold my breath when I do recommend this, but it always works. Now, what we more commonly do in our practice is a variation of graduated extinction. There are a lot of variations of graduated extinction. Pretty much every parenting sleep book out there, from Jody Mindell to Dr. Ferber to the Sleep Lady Shuffle to the No Cry Sleep Solution, they're all variations of graduated extinction. They all work. They all work differently for each family. So one approach is not going to work for every family. You have to find what it is the family is willing to do. So in a graduated extinction approach, the child still, we want them to learn to fall asleep, but focusing only on bedtime. And the idea being that once a child learns to fall asleep at bedtime, they will learn to put themselves back to sleep with each night waking. So if a child is waking every hour, which is a normal developmental thing, instead of waking 1 hour later to wake their parents up, they may put themselves back to sleep for that first waking and not wake up until 2 hours later. And so if a child learns to fall asleep independently at bedtime, within about 2 weeks, they will start to sleep longer and longer stretches at night, and eventually they will sleep through the night. The two most common approaches for graduated extinction are the checking method and gradually removing parents. For the checking method, the checks are based on parent tolerance, how much crying can they handle, and child temperament. So some kids, when a parent comes in to check on them, just seeing their parent is enough to calm them, and that's okay. A lot of children, when a parent comes in to check on them and then leaves, it makes them even more angry. And those are children for which this method isn't going to work. The checks are very brief and they're very boring. The checks are for the parents. It really is the opportunity for a parent to go in the room and to say the child, to lay them down, to wipe the tears and to say, I love you, it's sleeping time, and to leave. That does nothing to reassure the child, but it can reassure the parents. So checks are for the parent and they're brief and boring. And how often you spread the checks out, that is just based on what the family prefers. So again, each method recommends something different. Dr. Ferber recommends you go in 1 minute and then 3 minutes and then 5 minutes. Jody Mendel says pick an amount of time and go in about that same amount of time. And so I say to a family, can you hold out for a whole minute? And they're like, oh, we can hold out for 3 minutes. And I say, good for you. So only check on them every 3 minutes, right? You've got to find that sweet spot where a family is willing to do this. Otherwise, you won't be successful. So the checks, again, once a family gets comfortable with it, they start to spread out the amount of time between checks with the goal that the child will fall asleep while the parent is out of the room. Moving parents out is for the child who is okay with the parent being in the room but not holding them. So you put the child into the crib and the parent sits on the floor next to them until the child falls asleep. And then the next night, the parent moves a little further away until the child falls asleep. And the next night, a little further away. And gradually the parent moves themselves out of the room. Again, for some kids, that's great to have mom, dad, grandma, aunt, whoever it is sitting there with them while they fall asleep. But other kids, if you're there and you're not holding me, I'm going to be really mad. So this is why I say one approach does not work for every family. Graduated extinction, there's less crying involved. And with the checks or with the being present, it feels a little bit better to parents. That said, it does take longer than standard extinction. It can take a couple of weeks before the checks are spread far enough apart, or it can take a couple of weeks to move the parent further away. Also, those nighttime awakenings, they're going to continue because we're not ignoring them. And parents need to pick a consistent response. So what parents will often say is, well, the first time I went in, I just patted them until they went back to sleep. And the next time I went, I nursed them, but then I put them back in the crib. And the third time I went, I just brought them to bed with me. Okay, well, again, this young child is playing the slot machine. They just keep waking up and crying because sometimes they get fed, sometimes they get to go to the parent's bed, right? So that inconsistency actually perpetuates wakings and makes them last longer. And so you need to pick a consistent response. If eventually the parents are going to bring the child to bed, making sure it's a safe sleep space, then bring them to bed the first time and be done with it. We do discourage picking children up for comfort because that, again, only reinforces that need to be held. And then other issues in terms of the vomiting and one parent undermining the process is still similar. All right, these approaches work and they work well, and there is a lot of evidence to support them. The best randomized clinical trial was a long-term 5-year trial conducted by Hiscock and Wake and their group in Australia. And after the 5-year follow-up, what they said is that behavioral sleep techniques have no marked long-lasting effects. Parents and health professionals can confidently use these techniques to reduce the short to medium-term burden of infant sleep problems and maternal depression. So how do I sell this to parents? I sell it to them in that you are doing this for your child because they feel guilty. They're like, I'm doing this because I need more sleep. And I'm like, yes, but if you get more sleep, you will be a better parent. What we know from this evidence is that at 5 years, it really doesn't make a difference. There's no issues with attachment. There's no issues with behavior problems. But what we know is that when children are ages 2 years and 4 years, those that never learn to sleep independently or have this ability for positive sleep associations, their mothers are depressed, higher rates of depression. And we know maternal depression during early childhood is related to a whole host of negative outcomes, including higher healthcare utilization and more behavior issues and more attachment issues. And so it's not the sleep and the crying that's going to be the problem. It's going to be if you don't do that, you're going to have depressed mothers. And so that's how I help to convince families that this is really the right thing to do. Another trial that came out from a different group in Australia looked at some of the other things parents worry about. So these are kind of busy graphs, but what you need to see here, the graduated extinction, which is sort of that moving parents out, right? That's the dark black line. The medium gray line with these long dashes, this is bedtime fading. So this is where if your baby never falls asleep before 10 p.m., stop putting them to bed at 7, right? Wait until you put them to bed at the time they naturally are falling asleep. And then you can gradually move their bedtime back in the same way that we heard about with the chronotherapy. So, and then this last one is just standard care. They just got education. And you can see that in terms of falling asleep, both behavioral interventions worked equally as well. For wake after sleep onset, you can see graduated extinction works slightly better than bedtime fading, number of awakings. But here's where you really see the difference. Total sleep time, significantly more in children who had the behavioral intervention. Now, cortisol and stress are two big outcomes people worry about. And what this study shows is that there are no significant negative impact on infant cortisol, either in the morning or the afternoon. But what you do see are significant benefits in terms of maternal stress and in terms of maternal mood. So these interventions, they work. There are not negative consequences to them, but there are positive ones. All right, turning from infants and toddlers into our preschool and school age children. So now I'm talking about years 3 to 7, give or take. The first intervention is called take a break. This is just another type of graduated extinction, but it works a little bit better for older children, and especially ones that are no longer in a crib. Now, I do recommend keeping young children in cribs until at least the age of 3. And that's a developmental process, because at the age of 3 years, you can say to a child, stay in bed. And at 3 years and older, they start to understand that. Before the age of 3 years, they don't fully understand that. And all you're asking for is a child to hop out of their bed and wander around the home in the middle of the night. So this is for a child who is in a bed. And again, same goal, teach the child to fall asleep independently. And this is for a child who is currently falling asleep with their parent next to them all night long. So first you have to figure out how long does it take the child to fall asleep. So sleep onset latency. So let's say it's about 20 minutes for the child to fall asleep. So the parent then stays for half of that amount of time. So a parent lays down with the child, stays with them for 10 minutes, and then says, Mommy has to brush her teeth, Daddy needs to use the potty, I just need to go answer this phone call really quickly, and they leave. And the first few nights, they really only leave for like 30 seconds or 1 minute, and then they come right back and they say, I'm so proud of you for staying in bed, and the parent lays down with them and stays with them until the child is asleep. And that helps the child to understand, yes, the parent is coming back. Each night that break gets longer. Each night it takes the parent longer and longer to come back, but they always come back. Even if the child's asleep, you still want the parent to come back, because the one night they don't come back, the child will still be awake. But again, the goal is that the child is going to fall asleep while the parent is out of the room. Another approach is the second good night. So this is a checking method for older children. So again, you tuck the child into bed and then the parent leaves. And then the parent comes back at a set amount of time, every 3 minutes, every 5 minutes. And with older children, we pair this with that reinforcement that I was talking about earlier, or a reward. So the child is still in bed. When I come back, I'm going to put a marble in a jar, or a check mark, or a token, something very concrete and very immediate that says, I'm so proud of you staying in bed. Here you go. Now, if the child hops out of bed, then the parent takes one of those tokens or one of those marbles away. So very quickly, children learn to stay in bed until mom or dad or grandma or aunt comes back to check on them. And as this goes on, the child learns to fall asleep because the time between checks increases. A cute story of this, I did this with my son. He was at an age where he needed a nap. He didn't want a nap. So I would go in and I would give him a nickel, which is 5 cents, every time I checked on him. And then he would save up his money and we would go to a store and he could buy something. And he bought a stuffed animal once, and my mom took him to a friend's house and said, Ari, tell her where you got his animal. And he said, my mommy pays me to sleep. Okay, guilty as charged. But he got to take his nap. I got what I needed. He got a stuffed animal. We all won in the end, right? And so you have to sort of think about what is the end goal here, and getting children to sleep, especially at bedtime, is the end goal. All right, bedtime fading. So this is, I briefly mentioned this, but this is aligning the child's, or lining up the child's natural internal clock or circadian rhythm with that time that they're going to fall asleep, in order to reduce how long it takes them to fall asleep. So again, monitor their sleep patterns with a daily diary, and then delay their bedtime to match that time. So again, if they never fall asleep before 10 p.m., don't start bedtime until 9:30. This is the one that parents are most surprised by when I recommend. They don't expect to go to a sleep doctor to be told, put your child to bed later. But it makes a lot of sense when you think about it. Once the child is consistently falling asleep at that same time, then you move their bedtime up by about 15 minutes. So now, instead of putting him to bed at 10 p.m., you put him to bed at 9:45 p.m. You do also have to move that wake up time up if you are waking the child in the morning. And once they're consistent with 9:45, then move it to 9:30. And so it's very similar to what you had already previously heard. What we do with adolescents, you can also do with children. These are some other dirty little tricks that we use. A good morning light is a night light plugged into a timer. You have a timer that can automatically turn lights on and off. You can get these pretty much anywhere, and with smart homes now, they're really very common, but you can get very inexpensive versions of them too. And basically the idea is it's like a toddler alarm clock. So the light goes off at 7 a.m. And so throughout the night and at bedtime, you can point at the light and say, the light's on, it's still sleeping time, the light's on, it's still sleeping time. And as soon as the light goes off and the child is awake, you can say, look, the light's off. Now it's time to get up. And this just helps children to understand the difference between night and day. And again, depending on where you are in the world, that can vary. So right now in Denver, the sun is still coming up pretty early, 5:30, 6 a.m. In the wintertime, the sun's not coming up until 7:30, and children don't know the difference in time. And so if you base it solely on what time the sun comes up, it becomes inconsistent. So the good morning light works for that. The bedtime pass is a type of reinforcement where a child is given a very concrete pass or token and said, if you need another hug or if you need another drink, you can use your pass for that. But if you keep your pass, then in the morning you get an immediate prize. And so it just provides children who can delay gratification that ability to be in control over their desire for attention. The sleep fairy is like the tooth fairy. She comes once you've fallen asleep and she leaves a little something under your pillow. It can be a penny or a sticker or, a little chocolate chip in a baggie, doesn't have to be a big reward, but she comes after you're asleep. And this encourages children to fall asleep. And for the first week or two, she comes every night. Again, continuous reinforcement. This is the one time where an intermittent reinforcement schedule is very effective. After those first 2 weeks, we don't know when the sleep fairy is going to come. She's got a lot of houses to visit. So it keeps them guessing. Maybe tonight she'll come, maybe tonight she'll come, and it keeps them wanting to go to bed and go to sleep. Monster spray are for developmentally appropriate bedtime fears. Children fear monsters, and simply reasoning with them that monsters aren't real does not work. They will not believe you, and it does not make anything better. So monster spray is a bottle of water, and the children spray it around their room, and you tell them monsters are allergic to it, and if they get too close, they'll sneeze. And so you'll hear them coming, but they won't want to come close because it makes them sneeze. Or if you live in an area where there's a lot of insects, you can say monster spray looks like bug spray, right? It protects you and it keeps them from coming too close. And it gives children control over their fears by allowing them to spray the room to protect their area. Regardless of what you do, parents have to set limits. Parents have to remember that they're in charge, not children, and consistency is essential. All right, I'm going to turn to adolescent insomnia, and I think I'll finish so that we get back on scheduled track here. So you've heard a lot about circadian issues in adolescence. You've also heard that one of the things we have to think about is insufficient sleep, right? Teenagers don't get enough sleep. And so are we differentiating between insomnia, simply not getting enough sleep, or the circadian rhythm disorder? So this comes from the world of adult insomnia, but does apply to adolescents as well. And the 3P model of insomnia basically says, before you get insomnia, you are most likely predisposed to it. And that could be because you're an anxious person, or you have a family history of insomnia, or some other reason that increases your likelihood of getting insomnia. And then something happens. That's this green bar. Something happens, and now you have insomnia. So for example, COVID hits. Right? COVID hits and you worry and you lay in bed all night worrying, and now you're not sleeping because you worry so much while you're laying in bed. Now, over time, whatever that factor is, a death in the family, big exams, major stressors, that starts to decrease. But now we do things to sort of try and sleep better. Like, I only slept 4 hours last night, so I'm going to take a 3-hour nap today. Or I'm going to drink a lot of caffeine to help me stay awake. Or I'm going to try and sleep for 12 hours tonight. And even though I only sleep 4 of those hours, I'm spending 12 hours in bed trying to sleep. Those are all things that make insomnia last. And those are all bad things in terms of insomnia. And so once you cross to that point where it's less about what caused the insomnia and now what's just contributing to the insomnia, that's when you cross from short-term to chronic insomnia. So the first approach to treating this, and you've heard a little bit about this though, is stimulus control therapy. And so again, if you think about behavior therapy, like our bodies are trained to do certain behaviors. So I explain to kids, when your body jumps into a swimming pool or a body of water, you know not to go to sleep. right? Your body knows, it knows what to do. If you're riding a bicycle, your body knows it needs to be pedaling and balancing and not sleeping. When you get into bed, when you have insomnia, your body knows to worry and to think and to watch screens and to hang out and chat with friends and to do a whole bunch of things other than sleep, because you've not been using your bed only for sleep. And that's where stimulus control therapy comes into play, is that we retrain the body so that it only is sleeping in bed. How we do that is we use the bed only for sleep. So stop doing your homework in bed. Stop watching videos and talking to your friends in bed. Those are really important things. And with COVID especially, this has been really problematic. Here in the States, kids would wake up, pull out their laptops and go to class without ever getting out of bed. So that isn't very helpful. Sleep should only occur in bed. What you typically find in people with insomnia is they can't sleep in bed, but if they get out of bed and go to the couch, they sleep like babies, because the couch doesn't have any of those bad associations. But the problem is that now they're not learning to sleep in their bed or in their sleeping environment. As with anything, there has to be a consistent bedtime and wake time. Just because you didn't sleep well the night before does not mean that tonight you get to go to bed early. You have to maintain that consistent schedule to help train the internal clock and to limit your body so it knows when to sleep. Now, that said, a lot of kids are like, well, it's 10 p.m. I guess I should go to bed, but I'm not at all tired. Well, then don't go to bed. If you're not going to fall asleep, don't try and sleep, because you're only going to get frustrated. You have to explain the harder in life that you try at anything, no matter if it's a sport or athletic or, just being nice, the more you work at it and the harder you try, the more likely it is you're going to succeed. And that is true with everything except for sleep. The harder you try and sleep, the more likely it is you're going to fail. So if you're not sleepy, don't try to sleep. Now, this is the hard part. This is where I usually lose the kids. If you're not asleep within 15 to 20 minutes, and I rarely use that 15 to 20 minute limit because I don't want kids staring at the clock. What I typically say is, that point where your brain says, I'm not going to sleep, or I only have 6 hours before I have to wake up, or how many times am I going to wake up? As soon as you start having those negative thoughts, that's when I tell them to get out of bed. Get up and do something boring, right? So play cards, actual solitaire with real cards, draw, journal, listen to a book, listen to a podcast, something boring that doesn't involve a lot of light exposure, not in bed, and do that until you feel sleepy. And you have to do this at bedtime, and you have to do it if you wake up in the middle of the night. This is really hard, especially if it's dark and if it's cold and everyone else is sleeping and you're not. It's very, very difficult to do, but it works. And so convincing the teen, as was discussed in the last topic, you have to really get the buy-in in order to make this work. In combination with that stimulus control therapy, we do sleep restriction. And the idea being, again, you have to build up that homeostatic sleep pressure in order to feel sleepy. You also have to consolidate sleep so that you have that mild sleep deprivation and you're not expanding your sleep over long periods of time. So different ways of explaining this. One way of explaining it is, if you wore a size 10 shoe, if you wear a size 6 shoe, but I buy you shoes that are size 10. So clearly these shoes are way bigger than what your foot is. How's that going to work out for you if you had to run a race? It's not going to work out very well because your feet are not filling the space and it's not very comfortable. Well, same thing at night. If you give yourself 10 hours to sleep and you're only sleeping 6 of them, that's not going to work out very well for you because you're not using that time and space well. And then I have kids, especially those who like math, figure it out. If you're only sleeping 6 hours out of the 10 hours you're in bed, that's what we would call a 60% sleep efficiency. What kind of grade does 60% get you in school? Not a very good grade, right? So we've got to make it so that you're spending at least 85% of your time in bed trying to sleep. So that's what we do with sleep restriction. So how we do it is we use the diary to determine the average sleep duration, so how long they're sleeping already, and then you add 30 minutes to give them a chance to fall asleep. And then you choose their wake time based on school. So if they have to wake up at 7 a.m. and you're only giving them 7 hours to sleep, they should not go to bed before midnight. Again, that's the easy part. Kids like that part, going to bed later. The problem is they have to then wake up at 7 a.m. every single day, including weekends. If I'm feeling generous, I may let them wake up at 8 on the weekends, but they really need to try and stick with this schedule in order to keep their internal clock on schedule and create that sleep drive. And then you only move their bedtime earlier if their sleep efficiency is at least 85%. With teens, I find graphic visuals work really well. So they fill out this diary. What time did you get into bed and what time did you try and fall asleep? You can see this is not okay. You should not have this much time between getting into bed and falling asleep. What I tell kids is if your bedtime's midnight, you should not be in bed before 11:45. Then I have them guess, and this is important, just have them guess how long it takes them to fall asleep. Don't watch the clock. If it feels like 15 minutes, if it feels like 3 hours, I don't care what it actually is. I want to know what it feels like, because that's what we're trying to change, is that perception of difficulty sleeping. Then how many times they woke up during the night, how long they were awake for, and then what time they woke up and got out of bed. Again, you can see this is way too much time. To be in bed between waking up and getting out. So I tell them you have to be out of bed within 15 minutes of waking up. And then anything else, I had an exam, I stayed up late for a party, whatever it was, to help us understand. And then I take that data and graph it. So this is a 15-year-old boy who was told to go to bed at 11:30. Well, some nights he was tired, so he wanted to go to bed earlier than the 11:30. So that made it for a very zigzag bedtime. He was told to wake up at 7. You can see some days he had to wake up a little earlier, some days he slept a little later. It's not terrible, but not consistent. And what that ends up being then is it affects how much time of sleep he gets, and it affects his sleep efficiency. We're not getting nice straight lines. So we problem solved around some of these issues. I sort of read him the Riot Act about you've got to really do this. And we came up with how he was going to make it work. And 2 weeks later, this is what it looks like. So here's his bedtime. So 11 o'clock to 11:30. So he ended up settling on about 11:15 bedtime. And then his wake time, you can see, yeah, on a weekend day, he got a little bit later, but for the most part was sticking to between 7 and 7:30 wake time. It increased his sleep time. It was much more consistent. He was having fewer night wakings, fewer issues falling asleep. And you can see how this improved his sleep efficiency. And so that's how the process works. So in review, behavioral sleep disorders are common, but they are treatable, and all of these treatments do have empirical support behind them. There is no single intervention that works for every family. You really have to start where the family is at. You have to meet them with what it is they can do. You have to problem solve around the housing environment, the parents' work schedules, other children in the home. You have to find out family history. If you have parents whose own experience was very negative as children, they never want to let their child cry, you have to work around that. If you have children with chronic illness, I work with a lot of children with eczema who are very itchy and they scratch at night if a parent's not there. Those are not children I'm going to let cry, right? Those are children who will do a take a break the method with, because they need a parent present to keep them from scratching themselves into the point of bleeding. So all of these interventions work. They just need to be tailored and adapted to each individual family's needs. And that the behavioral sleep problems, they do work. They really do, but you have to have the consistency from parents for younger children, and you have to have the consistency and the buy-in from older children and adolescents. So thank you for your attention and for this opportunity. And I think we have time for questions, or we may just be jumping into the round table. I will escape from here.